Buenos días a todos. En el día de hoy vamos a tener un Ateneo un poco especial, porque un poco motivados porque han aparecido varios artículos en los últimos 2 meses sobre el mismo tema y un caso que tuvimos hace poquito. Elegimos este tema para hablar de la cirugía conservadora de testículo, los tumores benignos del testículo, probablemente benignos. Como tenemos el honor de contar hoy con 2 invitados extranjeros que no hablan español, vamos a hacer el Ateneo Bibliográfico en inglés. Así que a partir de ahora vamos a seguir en idioma inglés para aquellos que quieran verlo o que se pierdan algo. Cuando subamos el video vamos a ver si podemos colocarle los subtítulos en español para que todo el mundo lo pueda aprovechar. Good morning, everybody. We will be doing this morning journal club on the subject of testis-sparing surgery for testicular tumors. And this morning, our residents that will be doing the presentation and have been doing the research are Rocío Boudou, who is a 5th year resident, Paula Violo, who is a 4th year resident, Ignacio Bois, 5th year resident, and Carolina Percul, who is a 3rd year resident of pediatric surgery, our pediatric surgery training program. Next, our guests, invited speakers or guests to have their comments is Denis Cozzi, who is a friend from Roma. He is a professor at the Universidad La Sapienza in Roma and practicing at the Policlinic Umberto Primo Policlinico. And he's a well-known surgical, pediatric surgical oncologist, and he has been a leader and a pioneer in nephron-sparing surgery for renal tumors, and has also published with his group a very nice paper last month in Pediatric Surgery International, which is one of the papers we will be discussing today. And I would like also to introduce Paul Losty, who is also a friend. He practices for the last decades in Liverpool, in the UK. He's a very well-known pediatric surgeon who specializes in neonatal surgery and surgical oncology also. And Paul has collaborated with us in a paper we published on this subject also last month. So I think we should begin.
Good morning to everyone. As an introduction of today's topic, I'm going to talk about a case we worked on a week ago. An 11-year-old male arrives to the emergency department with left testicular pain. He refers an intense onset pain with improvement in the subsequent hours. Pediatricians ask for an ultrasound, and a left epididymitis and an heterogeneous calcified nodular image in the upper pole of the right testis are reported. The solid mass had defined margins and approximately a centimeter diameter. Patient is referred to pediatric surgery for evaluation, and physical exam reveals presence of a palpable solid lesion in the upper pole of the right testis. Tumor markers were negative, so testicular-sparing surgery was decided using an inguinal approach. Next. An inguinal incision was performed and the spermatic cord identified. Then the right testicle was pulled through the incision with an automatic clamping of the exterior spermatic cord. Then the tunica vaginalis was opened in order to visualize and palpate the tumor. Then the tunica albuginea was opened with a scalpel to minimize damage of healthy testicular parenchyma. Once the tumor was identified, an enucleation of the lesion was performed with a clear macroscopic margin of healthy testicular parenchyma. Hemostasis of the resection site was achieved with bipolar cautery. Next one. The testis capsule was then carefully repaired with an absorbable running suture, and then the procedure had ended.
Okay, continuing now with literature review. Let me introduce this article. We would like to briefly comment it. This article was published in Pediatric Surgery International, as commented Dr. Lobos previously, this year. Next, please. As you know, the management of testicular tumors in childhood has varied in the last decade. There has been a growing opinion with pediatric oncology surgeons that efforts to preserve native testes where possible should be undertaken with organ-sparing surgery. Prepubertal patients with testicular tumors and negative tumor markers can be presumed to have a benign lesion, thus avoiding a need of orchidectomy. This is linked to pathology analysis of many pediatric testicular tumors after orchidectomy, showing a high percentage of benign lesions. Organ-sparing operations for testicular neoplasm have been established at our pediatric surgical center now for more than 2 decades with good outcomes. Now continuing with method, a retrospective cohort study was undertaken. The next, please. Patients with diagnosis of a testicular tumor who underwent a testis-sparing surgery between July 1997 and August 2018 were included. TSS was indicated in patients if they met the following criteria. 1, evidence of a localized mass with spared testicular parénquima on preoperative ultrasound, and 2, negative serum tumor markers. Tumor markers analyzed included alpha-fetoprotein and human chorionic gonadotropin. On the other hand, to compare our study finding with published cohorts, a systematic review of the literature was performed with a screening PubMed, Cochrane Library, and embedded database. Next, please. Talking now about results. Eligibility criteria for TSS were identified in 12 patients. The median patient age was 10.5 years. Physical examination showed prepubertal status in 10 of 12 patients at primary diagnosis. Preoperative findings at ultrasound were in all cases more than 50% of normal appearing testicular parénquima, as you can see in the ultrasound picture, and a mean of 22% of the testicular volume was replaced by tumor, ranging from 4% to 30%. Most of the tumor were focal and discrete lesions. The next, please. Tumor pathology were as follows. As you can see, dermoid cyst in 41% of the cases, metric-teratoma in 25%, stromal tumors in another 25%, and a fibrous nodule in the epidermis. Continuing with results, the mean follow-up in this study was 73 months. No postoperative morbidity was documented, but an early tumor recurrence was found in a boy with a gigant surgery cell calcifying tumor, so a radical orchidectomy was later performed with no complications. No further disease recurrence were noted during follow-up of all other patients. A mean testicular volume variation of 20% of the preserved native testes compared to the contralateral non-involved healthy testes was noted at last ultrasound follow-up assessment. Serum tumor markers were within normal parameters in all TSS patients. Physical exams show an age-appropriate sexual maturation according to Tanner staging, as you can see in the screen. Continuing with the systematic literature review, database searching showed a total of 132 publications. After discarding duplicates and those not suitable based on language criteria, not available full text of those considered non-relevant, 34 eligible papers were included for final analysis. All of the articles reported clinical cohort studies or a small case series. Another click, please. Another one. Okay. Analyzed studies include 269 male patients, 94% having prepural status. The most frequent type of tumor encountered was a mature teratoma. This last responsible for 62% of the all resected lesions. A single paper reported tumor recurrence after TSS. Isamatsu published a recurrent mature teratoma that was later resected by orchidectomy 10 months later. Regarding residual volume of the testicular parénquima, Trobs et al. Recorded testicular atrophy after a tumor enucleation for a centrally located Leydig cell tumor in a 10-year-old boy. Now continuing with discussion. The next, please. Taskinen et al. From Finland recorded that 68% of prepural males will have benign tumors, while after puberty, the percentage of benign tumors falls to below 38%. Normal preparative serum tumor markers are considered by most pediatric oncology surgeons a mandatory prerequisite before embarking on TSS. Reassuringly, published data demonstrate that the likelihood of finding a malignant germ cell tumor in a patient with negative tumor markers is very low in the prepubertal patient. On the other hand, encountering a benign testicular tumor in a patient with preparative elevated tumor markers is distinctly uncommon. Histopathology findings in the present study are consistent with published literature, showing a broad predominance of benign tumors. So in closing, we wish to further highlight and promote the concept and feasibility of testicular sparing surgery in carefully selected patients.
This second article that we are going to present was published here in Pediatric Surgery International this year. In this opportunity, we are glad to have its author, Dr. Denis Cozzi, participating with us in this edition of the Journal Club. This article also begins its introduction exposing that testicular tumors are infrequent, and that as it is known that prepubertal tumors have significantly lower malignant potential than post-puberal ones. Testicular tumor surgery generally entails early clamping of the spermatic cord to prevent potential dissemination of tumor cells during manipulation. However, in this article, this group of surgeons described its preliminary experience using off-clamp TSS offered to 4 consecutive boys with benign tumors, with the goal of avoiding potential detrimental effects of worm ischemia for future fertility. This was a retrospective analysis that included 4 patients and 4 patients under 18-year-old who underwent this kind of surgery. The testes were delivered through an inguinal or scrotal approach. In one case, the cord was encircled with a basal loop, which was utilized for gentle upward traction. And in all cases, the spermatic cord was not clamped. The abutinea was incised using a cold knife, and the tumor enucleation was easily accomplished with blunt dissection. After frozen selection results, wounds were closed.
Well, as results, the article reports 4 pediatric patients with serum beta HCG, alpha fetoprotein, and LDH levels normal at diagnosis. US reports well demarcated avascular or purely vascularized intratesticular lesion, and frozen section of enucleated tumors revealed benign histology in all the cases. Soon, at clinical and ultrasonographic follow-up, ranging 7 months to 7 years, the operated testic volume was grossly normal in size in all the patients. This experience seems in line with the increasingly reported predominance of benign testicular tumors in pediatric patients, negative serum markers, and a favorable preoperative ultrasonographic characteristics may indicate a high probability of benign diagnosis, which justifies the increased interest in that technique. Therefore, TSS should be used in that patients and should be strongly considered. However, that approach can be curative, all patients need careful surveillance post-excision. Also, successful completion of TSS may be performed only if benign histology is demonstrated on frozen section. Literature review that the non-standard scrotal approach, which allows at less testicular handling as compared to the standard inguinal approach, has been safely adopted in more than 100 prepubertal testicular germ cells tumors, including 2 immature teratomas. Additionally, TSS without ischemia has been recently considered in some cases in adults with good outcomes. So, TSS with no clamping technique is an option, especially in infants and prepubertal children with suspicion of benign tumor, given the particularly vulnerable spermatic cord elements. Now we will talk about the main article. It's a systematic review and meta-analysis of TSS in pediatric patients, and it was published in January 2021. We know that the presentation in children is different than in adults, and that testicular tumors are traditionally treated by radical inguinal orchiectomy based on treatment experience in adult patients. But TSS approach has been increasingly considered in pediatric patients to maintain hormone function and fertility. It has been reported that that approach can effectively control that tumors in children and preserve their normal testicular tissue. However, the indications and facility associated with TSS are uncertain. So, in this article, a meta-analysis was conducted to investigate the clinical outcomes in children with testicular tumor.
The study conducted was a meta-analysis. The PubMed, Embase, and Cochrane library databases were searched from inception till August 2019. The following terms and their combinations were used to the search: testis-sparing surgery, testicular tumor, and children. In order to meet the inclusion criteria, the articles had to involve patients under the age of 14 years with testicular tumors treated by testis-sparing surgery. Primary outcomes were recurrence rate, benign rates, and rate of testis-sparing surgery. And if more than one article was published using the same case series, the study with the largest sample size was selected. On the other hand, experimental studies of animal models or cell lines, studies with same case series, and abstracts, case reports, reviews, and editorials were excluded. Data was obtained from all the studies by 2 independent researchers based on the eligibility criteria. Any disagreements between the 2 experts were resolved by reaching a consensus with a 3rd investigator. Here you can see the list of the collected data that was included. The quality of the cohort studies was assessed using the 9-star Newcastle-Ottawa scale. This star system analyzes the method of selection of the study groups, the comparability of the groups, and the assortment of outcome of interest in order to grade the studies. With a perfect score of 9 stars, studies with more than 6 stars were considered as high quality to be included. In regards to results, after a comprehensive search, a total of 194 articles were found. after removing duplicates, those with ineligible titles and abstracts, and those with corresponding to letters, reviews, and meta-analysis, the search came down to 24 papers. The content of the selected 24 papers was assessed. Out of this, 8 were excluded since the study did not focus on children, and 4 did not report any relevant data. Finally, 9 articles met the inclusion criteria. The study were conducted in 6 countries, and the sample size in each study ranged from 3 to 67 patients, with a total of 320 patients. The patients' age ranged from 0 to 14 years, and the admission date ranged from 1967 to 2015. Next. Recurrence rate was reported in 8 studies, varying from 0 to 20%. Benign tumor rate was reported in 9 studies, varying from 34 to 100%. The rate of testis-sparing surgery was reported in 9 studies and varied from 12.5% to 100%. The rate of testis-sparing surgery in benign tumors was reported in 9 studies and varied from 20 to 100%. The rate of elevated alpha-fetoprotein was reported in 7 studies, varying from 12.8 to 42.9%. As you can see, the teratomas were the most frequent tumor of the series, reaching a total of 159 and representing a 49.6% of the cases. It is intriguing that malignant tumors are the second most frequent and that they are even included in this paper, since this kind of surgery is contraindicated for those cases.
Finally, as we saw in these 3 articles, testicular tumors are rare in children. Benign lesions account for a higher proportion in children than in adults. Although germ cell tumors are more common than stromal tumors in children and adults, the majority of adult tumors are malignant. In contrast, the more common histologic features of childhood tumors are teratomas and Puriol cell tumors. This study revealed that the recurrence rate was about 6%, benign rate 70%, the rate of TSS was 36%, and a bit higher in benign tumors, 48%, and it was consistent with another previous study that confirmed that benign tumors accounted the majority of the tumors, and the most common histology was teratoma. Considering that the recurrence rate and the atrophy rate were low and the great majority of the tumors were benign, it is notable that the incidence, the rate of TSS was not so high. So half of the benign tumors have received a radical surgery. So this article, as the 2 previous ones, suggests that testis-sparing surgery should be provided in children with benign lesions.
Okay, thank you very much. It was a nice presentation, although a bit long. Why? Because it is not, we usually go through a single article in this journal club on Friday mornings, and eventually 2, but in this case, we thought that it would be interesting to talk about these 3 articles. And first of all, I would like to focus on methodology and talk about you know, how are we approaching this specific topic, or how has it been approached through I think 3 different papers from the methodologic point of view. So thank you, Denis, for being here. Paul, are you there? We want to.
Hi, Pablo. Buenos días, amigos.
Good morning, my friend.
Buongiorno,
How are
Denis.
you?
Come state?
Buongiorno, my friend.
Well, if you agree, I would like first first of all, to focus on methodology and talk a little bit about how these papers have been constructed, especially the last one. Both of you, Denis and also Paul, have published a lot of papers, and we're here in our meeting. We have usually a significant number of young surgeons. We have people from our hospital, but also from other centers from Argentina and also Latin America. So it would be nice to talk a little about. It's not so usual here to write, to perform meta-analysis and literature review. Of course, we are used to read them, but I would like your opinion or some comments about methodology. Beginning Denis first, please.
So first of all, thank you, Pablo, for the kind introduction, and congratulations to all your young surgeons, because rather than a surgical club, it looks to me that this is a real symposium. So congratulations for the fantastic presentation, very well constructed. So that's very important. It's a very good start. And secondly, as far as concern meta-analysis, I have to make a step backwards, because Paul Losty is a master. He has published several important meta-analysis, and so I leave to Paul the comments about the methodology of the presented study from the Asian Surgery, Journal of Surgery. As far as concern my comments, I would be very brief. First of all, undoubtedly, there is a changing pattern in epidemiology of testicular cancer in children. So your study, your extensive literature review, and the meta-analysis presented clearly shows that there is a high percentage of benign lesions as opposite of what was thought in the past. Secondly, ultrasound is a very non-invasive way that can give you a lot of information. So we didn't touch the sites, which is another important issue, I believe, because usually we all set this kind of conservative surgery for small lesions. So this is another important, as well as the echographic pattern, because the more cystic appearance, the more likely the benign nature of the lesion can be. And the last comment I would like to raise is about alpha-fetoprotein, because the maxim that you also stressed is that when the tumor markers are negative, it is really unlikely you are dealing with a malignant lesion. Whereas in the meta-analysis presented, as you noticed, they had a 20 to 40% of cases with elevated alpha-fetoprotein. So this, I believe, is a bias mainly related to the age of the patients. Because as all of you are aware, of course, especially during infancy, alpha-fetoprotein can be raised. So it is important when we talk about raised alpha-feto, if the value is still within what are considered normal values, or if these are real high level of tumor markers. And in fact, there is a discrepancy between this 40% and the high percentage of benign lesions. So I'm pretty sure that this high rate was because probably most of the patients with raised alpha-feto were in a very young age population. And so just to stress again what has been our step forward. So if we all believe that these tumors can be safely removed with a conservative approach, why not try to avoid any damage on the spermatic cord? Of course, there are no in vivo studies about the detrimental effect of the clamping of the cord, but there are some experimental studies in the rat demonstrating that worm ischemia may, after also 20 minutes, produce some problems. So what we are suggesting is that in cases you really think are dealing with benign lesions, even clamping of the cord should be one of the aspects to bear in mind. So I thank you, all of you, for inviting me, and I look forward to listen to the next comments. Thank you.
Thank you, Denis. We will be later discussing the clinical aspects of this discussion, which will be very, very interesting, I think. And your points we will be getting back later for that. So Paul, as Denis said, you have a huge experience in this kind of studies, and to begin with the very basis of this, please, I would like you to tell us about what is the difference between a systematic literature review and a meta-analysis, and what's your opinion on these studies we are dealing with today. Thank you again for being here.
Okay. Muchas gracias, Pablo. Let me just start off by saying that this is obviously a very topical field. It's more than a coincidence that we've had a paper from Argentina that I had the pleasure of working on with Pablo and his colleagues, that Denis has produced what is an excellent paper. And Denis, I do congratulate you for this, because it was something that I'd been thinking about. So great minds think alike as to whether you need to clamp the cord or not. And I think this is extremely important. And I think obviously the paper from China is an impressive number of cases, again, following the same theme of our paper published from Argentina and Liverpool, where we explored outcomes and indeed the state of the world literature. So for the young people, I say to young people, when I was starting out in pediatric surgery, I always used to question what if and what why. And it was working with Barry O'Donnell in Dublin way back in the 1990s that he used to say to me, what's in the comics this month? And I think that terming journals as comics really, for me, took away a fear factor that everything written in journals must be true and must be believed. So if you think of the journals like our newspapers, our Daily Argentina Post, or for the ladies, the Graziana Magazine, Hello Magazine, etc., do not let journals intimidate you. They're just articles written by people with an opinion, and not everything needs to be true. So do not shy away from a journal making you afraid of being inquisitive and having an inquiring mind in surgery. The second thing I used to always say as I grew up in pediatric surgery, much like many pediatric surgeons of my generation, why do we always believe what's written in the books? Because somebody wrote it 20 years ago. Well, time changes in surgery. When I qualified as a doctor, many things that are now available in pediatric surgery and surgery in general were not even believed, are not even thought possible. So if we move then to evidence-based medicine, where surgery, and including pediatric surgery, has been slow to catch up, it really was born out of Canada by David Sacker, who then later was involved in the Oxford Evidence-Based Medical Unit in Oxford University in England. So themes and manuscripts defining systematic reviews and meta-analysis uplift, if you like, to a different star grade level, the quality of what hitherto had been in the past considered narrative reviews. And reviews are only as good as the people that write them. And you will know, and I will know, that you've read some very great review articles on different themes of pediatric surgery. But the systematic review meta-analysis climbs to a different level of evidence in terms of its quality of information and the conclusions it's making. If you look at the pyramid of evidence or the hierarchy of evidence, in which they can be listed from grades 1 to down to 5, you will see at the top of that pyramid becomes randomized controlled trials and systematic reviews of randomized controlled trials, where you compare one therapy versus another in a double-blinded randomized manner with independent investigators looking at the results from those that drive the hypothesis in which they wish to test, and steering committees monitoring whether the study has achieved its aims and does not need to recruit further, or whether there's evidence of harm and the study should be stopped. So let me move on then to the questions of methodology. So within methodologies, the high impact factor journals define very clearly what they consider to be the entry criteria for a meritorious submission to a good journal in what is considered a 5-star rated systematic review. And these include the PRISMA reporting guidelines. PRISMA is an acronym for Preferred Reporting Items in Systematic Reviews and Meta-Analysis, of which these guidelines have just been recently updated again in 2021. The most recent one was 2209, and now 2021, there's a new guideline that has been revised. So, like a detective trying to solve a crime, you have your key suspects, testicular-sparing surgery, you have the other subject tumor, you put it into your filters, and you interrogate with your PubMed and Scopus and other databases that you should involve. And the data will then spit back at you or show you a list of fields and filters in which, as been shown by our colleagues in Argentina, you self-select what is considered the quality from the quantity. You're taking the quality from the quantity in terms of what really matters and where is that good information really going to lie. And then you analyze those studies, and then you can subject them to meta-analysis with various statistical packaging tools, of which one is readily available called Rev Manager, and there are other ones available on various platforms. Indeed, there's one statistical package developed by an academic at the University of Liverpool, where that computer, that machine, that artificial intelligence brain will get to work and then show you the data. And the data that a meta-analysis displays is what is known as a forest plot. We're not going into the woods here. It's called a forest plot, which will show you tables of the studies on the left-hand column with the confidence intervals as longitudinal lines within the plot. And then you see a summary diamond at the bottom of the results where the statistical package will tell you, where does this lie? Are we in favor of the sun shining today in Roma versus Liverpool? More likely. Are we expecting rain in Britain today more than Rome? Yes, more than likely. So that's what the diamond will come down on. So that gives you the outcome. And the strength of systematic review and meta-analysis is, one, they will tell you a trial is needed, or the questions can be answered without a trial, or more work is needed. So they're very powerful. If you look at the best surgical journals in the world, JAMA Surgery Impact Factor nearly 14, Annals of Surgery Impact Factor 10 to 11 to 12, BJS has Surgical Impact Factor in Europe, of which I'm on the editorial board, 5.6. These are the journals, the hotels you want to stay in, the Four Seasons, the Ritz, Carlton, etc., where these journals like this quality, because you're really in a different league here in terms of the quality of the narrative and the story you're telling. So for the young people, it's easy. All you need to do research is a brain, a computer, and an idea, and a good supervisor, a good mentor. You don't need a lab rat, a molecule, or £1 million grant. Research is never easier than it's ever been to do. Dennis will tell you, Pablo, in our day, we had to go to Index Medicus, big books like the encyclopedia. We had to write a note in the paper we found. Then we had to cross-reference, find another paper. Then we had to speak to a nice librarian. Could they get us the papers because they weren't in the library? And to even start to plan a study could take a year to write and complete. Now at the push of a button on a smartphone, don't tell me you don't know about academic surgery. I can sit in my pajamas here, drinking my Earl Grey tea, and I can write papers without even leaving my apartment. So for the young, this is the golden era you live in. You can rewrite history in pediatric surgery by reinterrogating the ideas, the old views and thoughts of the masters and giants in our field, and see a new direction that we should be going in. I just now want to pass a commentary about this topic, which is very, very important. Denis, I think yours is a great paper. I didn't review it. I would tell you if I did, but I certainly, when I read it, I said, there it goes, Cozzi's thought of it. I wanted to do it. And for the young people, you should know that Professor Cozzi and Father Litz, his father, the Senior Franco, Professor Cozzi, were the group in the world, the first group in the world that got us to rethink surgery for Wilms tumor in terms of preserving renal units. So Denis, you know I quote this when I write about it, so I just say you in person, congratuloni for that important work. So back to this topic. Yes, we should be saving more testes. Yes, we should be avoiding castrating young boys. And yes, this is an area that was first really pioneered by Michael Agualia and Robert Schamberger when they published one of the first manuscripts on testicular-sparing surgery in the late 1990s. We now know that, as has been said in these papers, with the biology, as Denis has referred to, and in the speakers, and age are really important determinants of whether testicular-sparing surgery can be carried out. Why? Because the demographics of the biology in the prepubertal patient is different. A significant majority of these boys will have benign biology and do not need orchidectomy. In the peripubertal and postpubertal patient, one needs to be extremely cautious because the biology can be different, and we see a switch to adult type tumors. I just give an example, perhaps seminoma, which would be marker negative. So you must be careful. The patient ideally should be prepubertal, should have a focal lesion and ultrasound, as Denis has mentioned, and there should be enough sufficient residual parenchyma in the testis that the procedure is worthwhile. There's no point doing a 95% nucleation and leaving a small nubbin of risotto rice or a small pea for the testis, because it may put out a little testosterone, but you really have something in the scrotum for that boy when he's an adult that he's not going to be very happy about when he grows up. He will need a prosthesis if he wants to meet with the ladies. Yeah, he may, excuse me, ladies, for saying that, but it's very important psychological and body image for a man to look as normal as a man. Yeah, and particularly the surgery for the parents and the dads are very important. The functional outcome, of course, as surgeons, but for us, the body image, well-esteem, and psychological health of the patient and family is what should be driving testicular-sparing surgery. Now, Denis's paper is extremely important because other than experimental work mainly in rodents, we don't know about the patients that have had cord clamping and their testicular outcomes. Obviously, in our own series is where we explore these patients, but it would be intriguing, and indeed, I throw this study out to the group as a collaborative piece of work, that it would be great if we could find patients who have had cord clamping and excision of a lesion, and find these patients and compare the size of the ipsilateral to the contralateral testis that has not had surgery. And I'm sure we would find, and Denis, I'm sure you would agree, we will probably find that within those groups that have had cord clamping, even with a soft vascular cramp, there will be growth effects on that testis. So to take that work further of Denis's, we need to find those patients. Quite separate from the studies that we have undertaken and shown that testicular development can be preserved, puberty will progress, and that child will grow up with two testes. So we need to find that population, and that would be done through retrospective cohort studies, through our own institutions and at a multinational level, where we could hopefully find these patients and compare testicular size with orchidometers. I think that's the comments I would finish with at this moment, Pablo. But I think we're seeing now a shift from what has already been occurring with ovarian-sparing surgery in the female population to now wake-up surgery happening in males. And we should have been doing many years ago when Bob and Mike LaGuaglia published that paper. I'd have one more comment, and that is the approach, the surgical approach. In time-honored oncological principles, it's always been said you should never violate the scrotum with a scrotal incision. But we know from the work of Adrian Bianchi, another pioneer and giant in our field, that cosmetics is important in surgery. And Adrian, of course, pioneered the development of scrotal orchidopexy without a groin incision. And I think in suitably selected patients with focal lesions with negative markers, the scrotal approach lends itself ideally to aesthetic surgery, virtually scarless surgery, for these young men when they grow up as boys to have a near imperceptible scar. So with caution and in the right patients, the scrotal approach, I think, is one to be considered for where we have a over 90% possibility that the tumor is likely benign. I'd add a final point on frozen section, and this tends to be institutional dependent. Our own pathologists in Liverpool are very good people, but they're rather anxious about reporting frozen section because they like to get it right first time. And I guess, you know, that can vary from institution to institution, but we've got to remember that the majority of these lesions tend to be benign dermoids, focal lesions, etc. So again, there's another study here. You know, if we were to survey pediatric pathologists, how many would be happy to report frozen section of the testicular lesion in an effort to preserve testicular organ-sparing surgery in a patient with tumor? And again, that's something I think Denis, Pablo, and ourselves, we could do that study by getting out, working through our pathologists at a national level. And again, that helps develop a consensus that may switch the concerns of some of our pathologists that are more nervous about reporting cesarean section. So thank you for letting me join you in Buenos Aires this morning. I have not been in Buenos Aires, I think, since the WOFABs. I love Argentina, viva Argentina. I love a nice steak. I love a vino red tinto de Calapso. And I also viva Roma, and I hope we all meet soon. There are my comments, Pablo and Denis.
Thank you. Thank you very much, Paul, and very, very complete comments about the different topics and focusing on clinical aspects of these papers. I think that the two aspects you have addressed are the ones that raised for the discussion after reading these papers. And the first one, and we have discussed it extensively when we were writing our paper, is about frozen section, and you have addressed this topic just 1 minute ago. And most of the surgeons who are doing testis-sparing surgery, Denis himself in his paper has showed that they are doing frozen section in every patient. We have abandoned this practice some years ago because we have the concern about the clamping of the cord, and so we were clamping the cord at the beginning of the surgery, and then we had to wait to do the tumorectomy, and then we had to wait for the pathologist to give us an answer, and it was a huge amount of time with the cord being clamped, and we were concerned about ischemia and what have been addressed before. So what we saw is that we have not a single patient after 12 patients with a malignant tumor. And if we had one, we all know that eventually we can go back to the patient and do an orchiectomy if, for example, a yolk sac tumor was found, with no significant impact on survival or oncology outcomes of the patient. So that's why we had abandoned that practice. When we did our literature research, some other centers were not doing it anymore. But I would like your opinion, Denis, on this. And I think avoiding clamping, it's a good solution. So we could do again frozen section, but is it really necessary? If you perform this kind of surgery in patients with localized tumors, with prepubertal boys with the negative tumor markers, which is the chance that you will find a malignant tumor there.
Thank you, Paul. I fully agree with you. Probably the pressure was mainly given by our oncologist. And as I mentioned in the paper, the largest lesion, who's the last one we came across, was in fact a frozen section given as fully benign mature teratoma, but in the end, they found a minimal component of small immature neural tissue. And so that's to over stress what you're saying, that a frozen section is not the 100% certainty that you are in the right side. Probably we are following it because this is a routine in the adult testicular practice, where instead the chance of having malignancy is definitely and significantly higher. But probably you're right, we can safely avoid it when there are at least 90% chance of clinical and ultrasonographic evidence that the lesion is benign. So probably this is something we can advocate.
Thank you, Denis. I would like to open the discussion. I am seeing here, there Dr. Puideval, who is joining us today, and there are many other experienced surgeons in the audience. So is there any question or comment? You can do it by the chat or open the microphone. Bebu, do you want to talk?
I enjoyed what I listened today. What happened with me that some of the patients that you showed in your series, Pablo, we started to do it at the Italian hospital back in the 90s, and we have a lot of doubt about do this. We decided to do it. What I will mention was my experience at that time that some tumors are very easy to do it, a tumorectomy or to inoculate the tumor or to do a sparing surgery. But what I mentioned to you that I had a really difficult to do it that in the stromal tumors or the granulomatous juvenile formal tumors, which is that doesn't have a very clear space, and well, that's something you have to have in mind. And second, what I would like to mention is also that, you know, we know what we can do with this, but it's always is potentially. If this, I mean, the clamping the core will cause this in some number of patients. We're not sure about it. But also to lift this tumor and this spare surgery will, in some patients will not. But what I would like to say is that if 95% of patients will do it well with this, well, we don't have to put this 95% of patients in the risk to have some problems, because the other 5 will not have this risk, which is, I don't have clear what to do. But I will say, well, I will do the same. I retire this year, I guess. But anyway, I will do it. I will recommend it to do it when it's feasible, when it's possible to do it, spare surgery. First thing. Second, I will still clamp in the core, in spite of what Denis will say no. And third, well, in some type of tumor, I will do it, frozen section. But anyway, that's what I'm thinking. And at the time of almost 62 years doing this. And Denis, you have a father working with you. Your father was a doctor?
But My father is still alive, thank God. He's 84 and he's still with us, fighting with a lot of medical problems, but he's with us.
I am 86, and I was at Roma back in 1987, and he drive me from the Vaticano, from the Bambino Jesus to the Sapienza to show my service. I guess it was your father, but you're
Of course, Professor Senior Cozzi, Professor Junior Denis Cozzi, of course.
Yeah. He's the only one real.
Gracias, senor.
I think we should address the topic of nephron-sparing surgery for unilateral Wilms tumor in another meeting, because as Paul has said, I witnessed Denis' presentations at surgical oncology, at pediatric surgical oncology meetings, where he was very alone there at the presenting his experience and advocating for preserving the kidneys in these children, and everyone was struggling and fighting with him. And now, if you go to the umbrella protocol, nephron-sparing surgery for unilateral Wilms tumors is a standard and is accepted, but under certain conditions. So you should be recognized for this. And I know that your father was the first one talking about this. So I think we are on time. I don't think we have more comments in the audience. To end this meeting, I would like to point out that, especially for young people, that we should certainly consider testis-sparing surgery for tumors that we think will be benign, but the conditions to do it safely is to carefully select the patients where we will be doing this. I think more evidence is needed for the questions of the need of frozen section and clamping cord, but I think we should keep researching on this. But if you have a small tumor, especially if it is have cystic features and negative tumors, negative markers are negative preoperatively, and you have a spare or healthy parenchyma surrounding the tumor, it would be, in prepubertal patients, it would be safe to preserve the testes. And I think that talking about the surgical approach, the standard approach for testicular tumors is the inguinal approach. But I think it's interesting that perhaps for carefully selected patients with a high possibility of benignity, scrotal approach may be considered, again, with negative tumor markers and small tumors and probably cystic tumors. So thank you everybody for being here. Thank you, Denis. Thank you, Paul. I miss you I miss very much to seeing you and meeting you there in person. So I hope this next year will be finally solve this pandemic problem, and we will meet again in a meeting or we'll be able to visit you.
Certainly. Thank you to you, Paul, for the invitation, and congratulations for your first class equipe of surgical young surgeons. God bless you, all of you. Fantastic.
They are really first class. I agree with you.
Yes, indeed, Pablo. Congratulations. Pleasure to be at the meeting today. Pleasure to join Denis Cozzi. We're good friends for many years. And call us anytime. This is most enjoyable to share our knowledge with the young people and continue to drive pediatric surgery forward for the next generation. So congratulations. Muchas gracias. Have a good weekend, everybody. Arrivederci, Denis.
Ciao, Paul.
Everybody. Bye-bye.
Always.
Thank you.
Always
Bye-bye.
first
Thank
class.
you. Bye-bye.
Bye-bye. Bye-bye.
Bye. Bye.
Ciao.
Bye.
Bye.
A presto. Ciao Paul.